Few definitions. Phoria, it is latent squint. Tropia, it is manifest squint. Orthophoria, it is an ideal condition in which the eyes are straight. There is no manifest or latent squint. Pseudosquint, it is apparent squint. It is a condition in which the eyes appear as if they are having squint, but in fact they are straight. The next picture shows the causes and the picture of a patient with apparent squint. The left picture shows epicanthic folds and a broad nasal bridge, and also a negative angle kappa. The right picture shows wide interpupillary distance and a positive angle kappa, which results in pseudo-exotropia. Pseudosquint is all about angle kappa, and in order to understand angle kappa, one must know various angles and various axes of the eye. So, what is visual axis? Visual axis is a line connecting the object of regard with the fovea, and it passes through the nodal point of the eye, which lies in the posterior part of the lens. What is pupillary axis? It is the line joining the center of the pupil with the center of the cornea, and this line is then extended anteriorly and posteriorly onto the retina. What is optical axis? Optical axis is a line that passes through center of the cornea and center of all optical media. Now, what is angle kappa? Angle kappa is the angle between visual axis and pupillary axis, and it is usually positive, and it lies slightly nasal to the center of the cornea. The light reflex lies slightly nasal to the center of cornea, and this gives a false impression of squint, and this gives the impression that the eye is turned outwards. So if the angle is large, it will be more prominent. If the angle kappa is positive, it gives the impression of pseudo-exotropia, that is in hypermetropia, and if the angle is negative, then it gives the impression of false esotropia that occurs in high myopia. Concomitant squint. It is a type of squint in which the eyes maintain the angle of deviation in all directions of gaze, and there is no restriction of ocular movements. Causes: high refractive errors, abnormal AC over A ratio, normal is 3 to 5, and if the ratio is high, the patient is likely to develop convergent squint. Convergence center abnormalities, defective fusional mechanisms, decompensated latent squint, sensory or afferent abnormality, meaning defective vision, and hereditary. Latent squint. It is a tendency to develop squint which is kept in check by fusional mechanisms. When these fusional mechanisms are broken down, squint becomes apparent. It is also called phoria. Features. All the features are grouped in asthenopia. These include eye ache, headache, blurring of near work, crowding of words, intermittent diplopia, and development of intermittent squint. Diagnosis is made by uncovered test, Maddox rod for far, Maddox wing for near. Treatment. First and foremost is correction of refractive errors, then orthoptic exercises which strengthen the weak muscles. Rarely prisms can be used and surgery can also be done. Maddox rod test. This test is done to detect phorias. Maddox rod consists of red colored cylinders mounted parallel to each other. These cylinders turn a spotlight into a red colored line at right angles to their axis. Now the patient is advised to hold the Maddox rod horizontally in front of the right eye, and the left eye observes a spotlight 6 meters away. The top picture shows what the patient sees if there is no horizontal phoria. Images from both eyes are superimposed on each other. The middle picture shows exophoria. In this, the red line crosses towards the left side and this patient has exophoria. In the lower picture, the red line remains on the same side and this is interpreted as esophoria. This is Maddox wing test. This test is used to detect phorias for near. Right eye sees the arrows and left eye sees numbers. Patient is asked to see or tell the numbers which the arrows point to. In orthophorias, the numbers will be 0, 0. If the number is even, there is exophoria, and if the numbers are odd, then there is esophoria. Types of concomitant squint. Concomitant squint may be isotropia, when the eye deviates inwards, exotropia, when the eye deviates outwards. The eye may deviate upwards in hypertropia, downwards in hypotropia, and may be intorted or extorted, that is encyclotropia or excyclotropia. Briefly, various types of esotropia. Esotropia may be congenital. In congenital esotropia, the angle of squint is large and there is cross fixation, meaning that in right case left eye fixates and in left case right eye fixates. The refractive error is normal for age. In young age, it is usually 1 to 3 diopters hypermetropia. Nystagmus is frequently present. Then esotropia may be accommodative and non-accommodative. In accommodative, it may be number 1, refractive. In refractive type of accommodative esotropia, there is high hypermetropia. The angle of squint remains same for near and far, and the AC over A ratio is normal. Second type is non-refractive, in which squint is more for near work. Refractive error is normal, but the AC over A ratio is high, that is more than 5. In mixed variety, the deviation is more for near. There is high hypermetropia and there is also high AC over A ratio. Non-accommodative isotropia. It includes stress-induced, sensory deprivation. Whenever there is loss of vision or reduced vision in eye below 5 years of age, the eye tends to deviate inwards. It can also occur in divergence insufficiency, spasm of near reflex, and consecutive, meaning when surgery is done for exotropia, the divergent eye is made convergent. This picture shows an infant with right esotropia, right convergent squint. Exotropia or divergent squint. It can be intermittent or constant. Intermittent occurs in young age. The patient is emmetrope or myope. It is precipitated by fatigue, ill health, inattention, and bright light. So when there is exotropia, the patient complains of diplopia. And this intermittent exotropia is usually preceded by large angle exophoria. Constant. Number 1 is congenital. It has characteristics common with congenital esotropia in that this has large angle and it's constant. There is heteronymous viewing. As both eyes are used for viewing, amblyopia is uncommon and refraction is normal for age, that is between +1 and +3 diopters. Hypermetropia. Number 2, decompensated intermittent means that after a phase of episodes of intermittent exotropia, this becomes constant. Number 3, sensory deprivation. After the age of 5 years, if there is visual loss in one eye, that eye assumes the resting position of the eye, that is in exoposition, and exotropia results. Number 4, consecutive. It means when we do surgery for esotropia, miscalculation has been done and the eye is rendered exotropic. This picture shows a patient of right exotropia. Treatment of concomitant squint. First of all, there is evaluation. Visual acuity is checked. Extraocular muscles are checked. Cover and uncover test is done. Alternate cover test is done. Maddox rod and Maddox wing test in 4 years. Then the angle of squint is measured roughly by Hershberg test, and then Krimsky's test is done. In specialized departments, all this testing is done on synaptophore. Cycloplegic refraction is done. Fundus is examined. If there is amblyopia, it is treated first. If there is a refractive error, full cycloplegic refractive correction is done. If required, bifocal glasses are given. And lastly, if all else fails, surgery is done. Hershberg test. It is a rough method to calculate the angle of deviation. In this test, the patient is asked to fixate on a pen light held by the examiner nearly 1 meter away. In order to estimate the degree of deviation, one must remember the following. 1 millimeter is equal to 7 degrees is equal to 15 prism diopters. So if the corneal light reflex is deviated by 2 millimeters, then 2 into 7, the deviation is 14 degrees, and 15 into 2 is equal to 30 prism diopters. Or if the reflex is at pupillary border, the deviation is 15 degrees, and if it is at limbus, the deviation is 45 degrees. The picture on left shows cover-uncover test being done, and the picture on right shows prism cover test being carried out. Cover test. First, Hershbox test is done to determine which eye is deviated. In the picture, the right eye is deviating medially and there is convergent squint. So, the left eye, that is the normal eye, is covered and the behavior of right eye is noted. If the right eye has vision, the right eye will move from medial position to the center to take up fixation. In the meanwhile, in the undercover eye, as per Herring's law of equal innervation, the medial rectus acts and moves the covered eye medially. This finishes the cover test. Uncover test. Now the covered eye, that is the left eye, is uncovered. The left eye will immediately take up fixation by moving laterally, and at the same time the previously uncovered eye, that is right eye, will become convergent again as the yoke muscles receive equal innervation. This finishes the uncover test. Interpretation of this test: right eye has convergent squint. Another scenario can take place when the covered eye is uncovered. The covered eye, when it is uncovered, that is, the left eye may not move and remain deviated, and the previously uncovered eye also remains unmoved and takes fixation. So interpretation in this situation is that the patient has alternate convergent squint. In phorias, the eyes are straight initially. Now look at the right picture. The eyes are straight. So one eye is covered, that is, left eye is covered. Now the fusion has been broken. So left eye deviates outwards, but the right eye remains fixated. Now the eye is uncovered and immediately the left eye takes up fixation and the eyes become straight by the process of fusion. And this is exophoria. Alternate cover test. In this, the eyes are covered alternatively in quick succession, and this calculates total deviation, that is phoria and propia. Krimsky's test. A prism bar is placed in front of the fixating eye and its power is increased until the corneal light reflexes become symmetrical, and the angle of deviation is calculated by the power of prism used.